And welcome to the Two Medics podcast. Just a quick shout out to our sponsors, mah.uk.com for medical accountancy needs, and also to Lifeline Healthcare Group.co.uk for the best locum rates. Hello and welcome to another episode of the Two Medics podcast. My name is Imran Laskar. I'm a consultant radiologist.
Hi, I'm Trusha Gunawardena. I'm a cardiology registrar subspecialising in intervention.
And we have a guest with us today that we have interacted with a few times, pretty well known to Med Twitter. And today we're hopefully going to go a little bit more than skin deep. Get it? Nice. Please do introduce yourself.
God. Jeez.
What? Come on. That was always coming. It's like when they ask me, tell me if it's a boy or a girl. It's the same thing. It's the same thing. Go on.
I had a quid for every skin pun. Hi, everybody. I'm Dr Jonny Guckian. I'm a dermatology reg in Leeds with a specialist interest in medical education.
Nice. Wow, there you go. And what an accent. What an accent, don't you think?
Yeah, so smooth.
So soothing. So tell us a bit more about yourself, mate. You're saying you're into medical education. I mean, it's a bit more than that, mate. I mean, you're pioneering social media, medical education, all sorts, no?
Yeah.
I'm kind of like, you know how whenever you're trying to apply for med school and you do like Duke of Edinburgh and do all these like swimming certificates and all that, I basically just like never stopped. I just kept doing all the annoying CV things. So yeah, I do a few bits and pieces. I do social media for ASME, the Association for the Study of Medical Education, and I did my master's in med eds last year on basically kind of on Med Twitter. Med Twitter got you guys got coded.
Yes.
I don't know if you'll make the paper yet, but right now. But yeah, honestly, it was that was great fun and learned loads about. It basically meant that I could sit down and go on my Twitter and not feel like I was procrastinating.
Nice.
Which was great. And so I do a bit of stuff for our Royal College of Physicians Edinburgh as well. So social media is my vibe, and it's a little bit different living in social media med ed land to being in dermatology land, but I'm trying to like bring the two together.
Fair enough. You also do a podcast.
Oh yeah. This is my well, I brought in the BJD, British Journal of Dermatology's podcast, and I mean that's just trying not to be a really boring nerdy journal club and have a bit of a chat about what like the real implications of dermatology research for patients, which is it's good fun, but again, I keep getting comments about my accent, and I didn't realize it was quite a thing. Honestly, when I went to I was at a conference last month in Boston. And I interviewed a couple of Americans, and they were like, "Oh, you've got the voice. You're the guy with the voice." I was like,
nice.
They all sound like me where I'm from. I sound posh for Derry.
I think that's been one of the fun things about having, meeting our guests and stuff, like getting to actually listen to the voices and the people behind the tweets, right? Like that's been really fun. And some people have been quite surprised about ourselves, Theresa, like as posh as we are, because, public school boys at the end of the day. And we say this every week, but God, what's been going on this week? Where do we even begin? There's been some absolute bin fires, some repeat offenders turning up this week. Some people might not want to name because of, I don't know,
legal reasons.
Yeah, they're quite litigious.
Yeah, maybe we could skirt around it if we really want to go down that subject. But what should we start with, Theresa?
Well, there was a kind of light-hearted topic on Junior Doctors UK. And honestly, because we're going to have to quote them a little bit later on for some very much not light-hearted comments or threads, we should start with something that's kind of fun, which was, what's the strangest thing you've ever seen a medical student do on the ward? And this isn't to poke fun at medical students. I mean, we've all been there and we've all done awkward things. But I mean, obviously it does. I guess we've all got stories, right, guys? Do you have things you want to share?
I mean, I've got one. I thought about this and I thought, like you, I didn't want to just poke the fun at med students and be too harsh from the get-go. So I thought I've got one that I did when I was a med student. I wasn't a very good med student. I was a bit of a dosser and just messed about a bit. But in my second year OSCE, my first station was a CPR station, and I went in. It was all going fine, but then they asked the question about what do you do whenever they're choking, and the answer I had to give was about an abdominal thrust. But in my panic, I forgot the words for abdominal thrust and instead said pelvic thrust.
Oh, nice.
So I just kept saying I would give this patient a pelvic thrust, and I just kept saying it over and over again. And the examiner was like, "What?" I was just laughing. Just more. Are you sure you mean pelvic thrust? And by this point, I was too far gone. I said, "Yes, I mean that," and he was just laughing his head off. And I got 10 out of 10 in that station. So
wow,
clearly got the joke.
You got to get 10 for the laugh.
So there, it's a new innovative treatment for stopping, preventing choking.
Yeah, wow, pelvic thrust. And I'm sure you'd want to get into that kind of thing. Yeah, so
thanks, man.
Thrusha, do you have any good stories from?
I mean, I do. I mean, like I did plenty of embarrassing stuff, but one of the things was when I learned how to do a neuro exam. And you know, like when you do checking proprioception, you do it in the toes, right? Where the one toe goes, you do up or down, right? I did it in every single one of the toes of this, you know, like we have to do the examination with everyone. Every single toe, and nobody stopped me.
That's like this little piggy, isn't it?
And they didn't stop me. And the thing is, I swear to God, like all these people must have just been sitting there, just been like, look at this guy. Like everyone's just watching. And sometimes, even now, even though medical school, that must have been like 2003, 2004. I still think about it sometimes, like, you know, like when I'm just doing something, it will like pop into my head. Like, do you remember when you were just doing the little piggy thing with like each? Oh man. Anyway.
Oh man, I mean, I really racked my brains trying to think about something, but you know, for some reason, when you start talking about that, you know, where you still think about something that happened years ago, and it still kind of gets you a bit now. Something still gets to me now. Like after we went on elective Thrusha, I think I went through some sort of minor, very low mood. Like I just thought, why can't life always be like that? Like it was just so good. We had such an amazing time traveling around the world and all this stuff. And then I think I just slept a lot. I just kept sleeping a lot. I don't know whether I was exhausted, and I kept missing loads of clinics. I mean, this allegedly, I may have missed a lot of clinics. And by the time we got to the end of the placement, obviously I tried to get signed off, and no one would sign me off because they'd never seen me before. And then I don't know whether I'll say this is lucky or unlucky, but the girl that was next door to me, who was on the same firm, I don't know what she was up to, but she didn't turn up either. And so the whole thing culminated that I had to go see like the dean or the postgrad dean or whatever. And we just sat in that room, and he was like, you know, where have you been for the last few weeks? And I just kept quiet. And then she started coming out loads of excuses. And I'm thinking, hey, you ain't never believe in that, man. I mean, I don't know where you've been either. And I just kept quiet. And I think, you know, I'm pretty done here, yeah. And he's like, listen, you know, I don't think I can pass you guys. I think you're going to have to fail this. And I thought, yeah, I saw that coming. And I kept quiet. And then she started crying. And I was like, ooh, that's a good idea. And so I kept quiet. And she started crying and crying and crying and then wailing. And I was like, oh, wow, she's really upset, mate. And I thought, oh, you know, and I was like, I'm really upset too. But obviously, you know,
I'm not going to cry.
Yeah. And then I just kept quiet. And then you could see how embarrassed he was that he made her cry and signed us off both. And that was it. We're done.
That's amazing. Whoa.
Yeah, genuinely, I still think about that. I still kind of, sometimes I remember like how, I mean, she was, and when he walked out, it was a little bit scary because when she walked out, she went, oh, thank God that worked, and walked off. And I was like, whoa. Yeah. I was
that's
just like,
so funny.
Damn, that's the skills.
3D chess.
Yeah, he got played. But then I made a comment. Yesterday about like Xander like tweeted something about whether I've ever been dragged before. It's about us talking about Jamaican patties, and he was like saying like, why did you describe the bag as oily? And I'm like, mate, I was like 6 years old. That's how I remember it. But anyways, like, have you ever been dragged? And I was like, no, because like I just genuinely start crying. And then Abby Carey replied being like, that's called the white woman defense. And I was just like,
oh.
Not saying anything.
I mean, if it helps anyone, that person wasn't of that complexion that did that, and I'm forever grateful for that little move. I think things would have turned out very differently if they didn't do that. So yeah, I mean, there's been a lot of, I mean, Reddit's been quite the source of a few funny things, isn't it? Or not funny things. There's been a few serious conversations coming up from Reddit this week, haven't we, Thrusha? Should we touch on another Reddit topic that came up? It was I don't know. Should we go for racism? I mean, that was
already
a big one.
okay. Already, yeah. Fair enough. As someone of God,
only because you said that you had a decent story, so I thought that'd be a good one.
Oh yeah, fair enough. As someone of color, how do you respond to a patient who is making racist remarks towards you or your team? And that was posted by. I feel like I have to say it because it says you laulalop. You laulop. you lalap. 2 hours ago. Oh, wow, that's a really fresh one. So it says, context happened today, and I just stood there baffled and walking away with internal screaming. Many a time I've done that, just internal screaming, because you just don't know what to do. And he said, the exact words were, my daughter's married foreigners, and the kids came out in all sorts of colours, yellow, green, blue, and a couple even looked like you. I mean, I wouldn't know what to say to that when they start to talk about all those kind of weird colours and stuff. I'm like, oh, okay.
Yeah, I don't know. I mean, when that kind of stuff happens, it's hard to really, stand up and say something, right? Like I always find it very awkward, and I think I'm kind of a bit more of a like, oh, can we just pretend that didn't happen and move on? That's not a good thing, is it? Probably should call them out on that. What do you think, Johnny? I mean, would you call people out on that kind of stuff?
I feel like you want to in the moment, but it takes bravery, takes courage, and unfortunately, it probably usually takes prior experience with it, and maybe a bit of role modeling and seeing other people having stood up to it. I mean, obviously, as the very extremely, like, the lights passing through me white guy here, I kind of tend to try to show up and listen in these conversations, but whenever it's not been anywhere near as kind of bad or hurtful as that, but get a little bit of anti-Irish stuff, a bit of anti-Irish Catholic stuff from time to time. A lot of like, oh, when I say I'm from Derry, say, oh, you're from Londonderry, and you just kind of be like, oh yeah, whatever, ha ha ha, same joke. But I would feel that in that situation, I'm afraid of conflict a lot of the time. So I don't know if I would have the guts always to stand up and be maybe a good enough ally. And I think that's something that as I say, takes a bit of practice and seeing what other people are doing and asking other people how they might deal with it.
Yeah, it's difficult, isn't it? Because like to challenge people, you are kind of, it's not just about, going into conflict with like another person. I mean, where there are like societal expectations of especially like being a Brit, right? Like maintaining, like not creating a scene. Like there's a scene thing, right? And if you call someone out, it's almost like even though that person might have said something that's completely horrendous, you're seen to be escalating by calling it out. And there's this thing about scene making or whatever. But then, and so there's that. But then also within a work setting, it's even more challenging, isn't it? Because then there's professionalism and all that stuff, that guise of professionalism, which I think people find like difficult. And I certainly found that is something that probably would have held me back from things ages, like, a while ago. Like I remember once a patient was shouting some stuff at a consultant, like on a round, and I was like, and it was on a ward round. It was so weird, and I was like, mate, what? Like I couldn't take it anymore. I was like, mate, why are you shouting stuff? And then he was like, where are you from? And then the consultant, like to me, and the consultant was like, oh, okay, let's just move on. And then afterwards, I felt like a bit like, where did that come from? And two, like, why did the consultant then decide that was an okay time for us to exit? And I don't know, it just was like this whole thing about avoiding creating a scene is there, but sometimes people need to be called out on these behaviors. Otherwise, how will they ever get a chance to learn that what they're saying is out of order? But I did have an example. Sorry, go on.
I was just going to say that there's this attitude of zero tolerance in the NHS. It's supposed to be zero tolerance to any kind of staff abuse, but that's just not a thing. I think we can all agree that there is that power dynamic with patients that you're expected just to kind of sit back and take it because they are the patient and it's almost like the customer is always right.
Yeah,
and
exactly.
We have to listen to their patients and make sure that they're, particularly if they're vulnerable, that they're safe and everything. But that doesn't mean that the power dynamic should invert so much that you should just sit there and take stuff like that.
I mean, from my point of view, I think obviously now, because I don't see as many people as I used to, but the odd time it used to come up, you've been there before, you've heard these things before, I've been there plenty of times. And so like, you just kind of for me anyway, maybe it's a bad thing, you just kind of get used to it. Like I think there was this running joke that I looked like, when Amir Khan had first come out as a boxer. So a few patients on the ward kept saying I look like Amir Khan. I was like, actually, I don't look maybe I don't think I do. But I don't think it was based on my actual look. I was the only brown person on the ward, and they just kept saying that. And then, it's like, well, am I really going to say anything to these guys? I just left it. Yeah, I don't know. You just kind of get used to this kind of stuff. And I just don't think, I often feel as though I could either have a really long conversation or just move on, and it's easy just to move on. And also we are talking about but the majority of the time you're talking to adults, right? These people have gone through their lives thinking the way they're going to think. One chance encounter with one brown person that answered back. Maybe I'm cynical. I just don't feel like it's really going to change all that much. So I just sort of leave it and move on, which is maybe, I don't know. I guess now I'm a consultant, I should maybe take it more seriously. I don't know.
I used to feel vexed about it when I thought people didn't do anything about it. But then I realized that, I mean, like, people are just going through different struggles, right? And so some people have the bandwidth and whatever to like deal with it, fine. And other people, if they're able to shrug it off and like rationalize it like you have done, which is like, look, they're not going to change, it doesn't affect me, off we go, then fine. But I used to always find that if I did that, if I tried to shrug it off, I'd be left with that kind of dissonance afterwards. And so the only way that I can kind of address it is by kind of responding a bit now, because otherwise I'll feel like, oh, what? In my head, the voice will be like, why didn't you say anything? Like I feel like that afterwards. And so it's purely for my own like sanity that like I say anything at all.
I've got to say, I've got to vouch for you on that one. When do you remember we were at that recent class, Thrusha? We're doing that class together, and then I think one of our colleagues made a joke that may have been quite inappropriate, but it was a safe environment because we we're all trying to learn about how to tell jokes and stuff like that. And Thrusha Meshka goes, "I'm going to say something." And I was thinking, oh no, we're going to have a scene. And I was like, and even though it was over Zoom and, nothing was going to happen, I was like, oh, please, Thrusha. And I don't know what I mentioned. Thrusha, please. And thankfully for us, the person who's leading the entire class actually called them up and said, don't ever make that joke again. That's a terrible joke to make. And you're not in a position to make that kind of joke and stuff like that. And I was like, oh, good for that guy, because obviously he was a professional in what he was teaching. But yeah, I vouch for Thrusha there, like, yeah. Whereas I was like, please, no.
Scenes will be happening.
Yeah. We're about to have a major scene. You're about to stand up and slap him around the face, Will Smith stuff. Yeah, which is a whole other conversation. But yeah, I think there was another tweet. I mean, I was kind of saying that, I guess now that you as you become more senior, you do feel like you're more responsible and you're kind of become more and more responsible for juniors. And I feel like sometimes people expect really good behavior because maybe you're seemingly at the top of the hierarchy, right? And I think I've seen a few little things turn up about like consultants versus juniors versus consultants. Did you see all that? There was I mean, obviously there was that kind of that was a tweet from Julia, I think this week, talking about how a consultant remembered her name. So that was quite an eventful thing for her. And she said it was a unicorn, which I would actually agree, because I don't remember half people's names half the time. They're just grey and white to me. But in terms of scan, by the way, and then but then there was this stuff about blood tests. Did you see that one, Thrusha and Johnny? There was something about blood tests being sent to the consultant in the middle of the night. That pulled a bit of a conversation, didn't it? A bit of a consultant junior divide or something, wasn't it?
Yeah, this is quite a thorny topic. So, Johnny, I feel like you navigate these spaces really well. Do you want to tell us about it?
I don't know. I think I navigate a lot of spaces, and some of them go a lot less well than others, to be honest. Yeah, I mean, I think this one was as much kind of that interdisciplinary divide between GP and hospital. And there was a bit of, because I know Phil Lee was involved in kind of in the corner of hospital consultants and saying, look, you know what, I can't remember the details of the issue. It was about who's responsible for taking bloods, and there was a lot of blame being thrown around, and Phil Lee was trying to kind of get rid of that blame and say we shouldn't be in the same swamp throwing mud around, which I thought was quite eloquent. And it's a really good point, because these things aren't about blame. There's the clear issue here was the system problem. It was that the service needed to be able to provide anyone who could take bloods, and so that the patients could be safe. And so you can only really navigate that particular problem by not blaming other people and just saying, look, this is what it is. We need to fix it. It's not the GP's fault. It's not the hospital doctor's fault. And instead we have, some kind of a tribal warfare between different specialties. Not always helped by particular role models in some of those specialties. I don't know if that was me just being a hypocrite and throwing some mud at a particular specialty person. But
I mean, no, you're right. I mean, so essentially the kind of tweet was along the lines of, oh, you wouldn't see a hospital consultant taking bloods, as a kind of corollary to the kind of assertion that maybe GPs might be expected to kind of fulfill the shortfall of not having phlebotomist bloods. And then loads of consultants being like, did some today, do a cannula today. We have to, sometimes we do. And you're right. Like but instead of just answering the kind of that issue that's happening with general practice, it kind of then just got compared with hospital consultants. Why? Like why? And I think when we were talking yesterday at the prelims, you made that kind of interesting comment about the new president of the Royal College of Physicians, so David Oliver, who kind of he wrote that article recently in support of GPs, and that's like a nice thing to see from the head of the Royal College of Physicians standing up for another specialty.
I think it's about communication, and I keep coming back to role modeling, but there's been, over the last couple of years during the pandemic, there's been a lot of really bad communication from kind of educational leaders and educational leadership organizations in particular, like with applying for foundation, exams, etc. And I think generally, even when kind of shit goes down, generally people can be understanding, and if you level with them, people are generally reasonable, and you try to show a little bit of empathy. But unfortunately, that doesn't generally happen a lot of the time. So we should celebrate it whenever there is good practice. So I think David Oliver is a good example of someone who communicates kind of well. He's on Twitter, and he wrote this article in the BMJ sticking up for GPs, even though that's not his particular camp. And to see a president of Royal College going into a major journal and defending another specialty was quite powerful, I thought. So he's a good egg, apart from being a City fan, of course.
Yeah, exactly. Do you ever see any of the other heads of the Royal College? I mean, can you think of any notable presidents of Royal Colleges who, I don't know, not mentioning any names, rhymes with Armada? Oh, well, anyway.
Oh, God. I wonder, Thrush, if you ever became a Royal College of whatever college.
Bodies everywhere.
Yeah, I do wonder that this is my time.
Yeah.
I think it is interesting because it's like it's still communication. What said unnamed president of Royal College is potentially doing. It's still a communication strategy, and it's they are advocating for their specialty, which is not necessarily in what everyone might agree is the most successful way, but it is they're still communicating and they're filling that vacuum. So that there is something to be said for that. But it's not. It's think before you tweet. Generally.
Yeah, I mean, I do sometimes wonder whether, because like sometimes when you see some of these college, whoever we may be alluding to, you just wonder whether they've got a bit of a chip on their shoulder, like they're just trying to get their own back. You know what I mean? Like maybe they've had repeated occasions of having a bit of a hard time with someone and decided that now I'm in a position of power, I'm going to say what I want because I'm the college person, whoever. Kind of brings you to our favorite Twitter account, Fesshole. So I'm going to read this one out. My maths teacher didn't like me at school. Years later, I bumped into his daughter at university. One thing led to another, and I ended up going back to her place. I think you know where this is going. The most enjoyable part of the encounter was imagining how cross he would be that I can't even say it. Shagging his daughter. I'm going to get in trouble for saying that. But yeah, I mean, that's one way to, I don't know, get back at someone.
How did we segue from presidents of Royal Colleges to this?
I'm reeling.
Skills.
Can I just say that? Can I just say, as a chair of a Royal College committee, I am not wearing my Royal College hat tonight. So I take no responsibility for any Royal College discussions.
I just love that. I think Thrush is the one that introduced me to Fesshole, and I swear every time I see that little logo, I just love. And every time I get the chance to bring it into our podcast, I just love it. I love it, and that was just a very sad excuse to try and bring it in. But anyway, sorry. Okay. Present company. I should take into account present company. Look, here's a tweet. Grant Ingrams said, patient with occurring minor rash over many years, triaged by 111 to be seen within 2 hours. The system is broken. Johnny, would you not need to see that kind of thing?
It's triaged by Johnny. That's why.
It's completely. It's completely outrageous. It should have been 1 hour. Like
steroids, quick.
Yeah, look, in dermatology, it's a fact. It's generally accepted that we don't need to necessarily see everything all that quickly. However, there are a few things there are emergencies. Just my usual thing. There are dermatology emergencies, but just don't call me about the little spot you've got just at 4 a.m. in the morning. Thankfully, I don't do nights anymore. But that tweet reminded me of a 111 thing that I heard when I was a med-reg, and it said basically a patient who was told that they needed to urgently come into A&E because they said that they were bleeding when they were on their period.
Oh wow.
Okay.
Right.
But then how do you get to, I mean, that's quite the segue, isn't it? Going from there
Yeah,
to
well,
you,
they just said that they ticked a box, or said that they said, "Are you actively bleeding?" And they said yes. So they said, "All right, into A&E you go."
Right.
Wow. Oh, wow. I
It's
mean, I
funny.
always think, do you remember in Scrubs where I think
I was
someone
literally just going to
collapses?
mention this.
Yeah,
Is this
oh,
the
go on,
dermatology
say it.
emergency? Is this the
Yeah,
dermatology?
yeah, yeah,
And the
yeah.
dermatologist is like, dermatology, and like his bleep had gone off, and he's like telling everyone, a dermatology emergency. I'm gonna go. It's a dermatology emergency. Like, was he so excited? Must have his little face. Is that what you're going to say? That episode?
Yeah, yeah, and then he turns up and everyone's like, "Do you have any money?" And they're like, "That's all you think I'm good for." And he walks off.
You can tell that's in America. I have no money.
Give it time,
Yesterday,
mate.
right?
Dermatology, come on.
Yeah.
Yeah, yeah.
Well, yeah. I mean, if, I am happy to sell my soul to big Dermavate if they want to.
Oh, mate, just rename something Guckian cream and just say, "Wouldn't you like some Guckian on your face?"
Okay.
That just sounds. You're going back to the Fesshole thing, right?
Yeah, I know. That sounds so wrong.
Trying my best. I'm dragging the podcast down
God.
a few notches.
Well, speaking of like terrible links, but the Daily Mail, I guess, whilst we're talking about just kind of like just disgusting things, the Daily Mail, like I just thought it was interesting to see there was a headline from them very recently, which was "Where have all the GPs gone?" And like it was the sheer like brazenness of it, and it's good to see like my Twitter all had the same joke, which was like, seriously, Daily Mail, seriously, that's what you're going to say? Like, after relentlessly bashing them with kind of absolute nonsense for ages, and now you're going to be like, oh, they've gone, like, where are they? It just seemed it's like a joke, right? It's like a comedy writer's written it, surely.
Yeah. They kind of like keep beating you down, beating down, and then when you leave, you're like, "Oh, hang on, why are you leaving? What's wrong?"
That's actually an article.
Yeah.
There is an article. That was the article from David Oliver, wasn't it?
Really? Okay.
It's just so silly because like I remember back during the strikes, just before the strikes, they said that they wanted to get 6,000 new GPs, and they managed to get something like minus 1,000 or something, or maybe even worse than that. And yeah, we're trying to get new medicals. We've got new medical schools trying to get increased student numbers, and then we've got FY1 waiting lists that are like 700, 800 people, which is going to get worse. It's because there's just no strategy throughout and communication throughout the whole thing. It's like you're going to increase the student numbers, but not the number of places, and you've got bottlenecks at everywhere. It's just it's really annoying, and we have to fix it.
Well, I just was thinking, well, I mean, is this a good time to talk about the stuff that's going on with the Royal College of Emergency Medicine? Because that's generated a lot of discussion. I mean, I saw like a response to some furore where they're basically talking about advanced clinical practitioners. And I think there's a statement they made saying we support them and we essentially see them as equivalent to CT3s. So I read that, and I was just seeing quite a lot of responses which are especially there was some stuff on Junior Doctors UK, but also on Twitter, where people are quite upset by that. And there's just like a lot of discussion back and forth. What do you guys think about? I mean, obviously they have a recruitment crisis, don't they? Emergency medicine. So the Royal College are probably trying to kind of toe some line. What do you think?
Yeah, it's difficult because on one hand you can see why people are upset in that the process of an ACP getting to that equivalent stage does not necessarily require the years of experience, thousands of pounds in exam fees, and hoops to jump through. And so it does seem very unfair for those who are CT3 kind of equivalent as doctors. If you're a part of a college, you may expect your college to stand up for you, kind of doctors first. But at the same time, on a systems level, we need to have a more diverse workforce in terms of, well, both in terms of obviously with diversity, and I know we might talk about that later, but in terms of the different roles that you've got, because there's not enough doctors. So you have to be able to empower and support your kind of allied health professionals as well. So I don't know if there's a winner with this, and Reddit really doesn't seem to like this particular argument.
No.
I mean, I always find this difficult, and I think there is an equivalent with what we do in terms of like they would, there's a lot of reporting radiographers these days that do a lot of, plain films, and some are doing CT and some are doing MRI, and there's a lot of people that aren't entirely happy about that. I mean, that's the only equivalent I can draw. And I always think to myself, well, the thing is, we've got a problem, right? So you don't have enough medical people in general. You probably don't have that many people going into emergency medicine in the first place, because it doesn't sound like the nicest or lifestyle friendly job. And then so when you've got these problems, how do you deal with it? And so then one of the issues may be to try and get another subspecialty to try and come in, or another specialty to try and come in and help. But then, then you got to think about, like, what are you really trying to do here? Because people, I think from the Reddit thing that I saw, they were complaining that you didn't go through 5-year medical school and all this kind of stuff. But I think all of them would probably sit down and say all of that stuff was probably, all that moving around and all those things probably weren't actually that helpful towards their training. It didn't actually bring anything to their training, right? Like, I don't see how any of that stuff can be like, when I think about what I do now, like, how much in med school do I really remember? Do I really need to go to med school to do that, do all the stuff that I do? For me personally, I don't think that's the case. And I don't know if that's the case for every single subspecialty medicine. And I think we spoke about this in a very early episode, Theresa, about, like, sometimes I feel like, are we pulling the ladder from under us? Because not everyone gets to go to medical school. Not everyone can go to make those sacrifices. But there is a point where someone they might actually be good enough. They might actually be good enough practicing wise to be a certain level. I don't know, like ST1, ST2. I don't know. Is it so bad that they can help or be treated on equivalent level? I don't know.
Yeah.
When you need the numbers, and if they're doing the job, then are we just upset because they didn't go through the hardship that you did? Is that what's required? I'm not EM, so I guess I don't know.
Yeah, same. I feel the same. Like, I'm not EM, so I don't know. All we can do is really kind of regurgitate what we've kind of seen. And one of the things that's seen is that it's really even though emergency medicine as a training route looks horrendous, it is still oversubscribed. It's still too
I rate anyone that does it, honestly.
Yeah, but there's oversubscribed, so there's more applicants than there are jobs. And so the argument about filling rotas and stuff, I guess the counter argument is like, well, you have got people who want to do it as doctors. And then they're saying, I mean, is it, and I saw one reply, which was like, as a doctor, can I apply for those roles? Can I do it as like an ACP? Like, because why do I have to do all those stupid exams then? Why can't I just do it? Why can't I do it that way? And then the other people are saying, well, ACPs, they do have to have experience, but probably, as a nurse or a paramedic, and but still lots of experience, just in a different role. So there's that as well.
I think some of it again is a bit that the mudslinging argument we talked about earlier, when actually the problem really lies further up, and it's the bottlenecks that you talked about, and the funding for places. Ultimately, we need to be able to fund more doctors, and if we don't have more doctors, then you can't just go for kind of cheaper. Well, how should I phrase this? I think that if you have more doctors, the doctors are going to be happy, and they're definitely going to be happy to have more support. Everyone is happy to have more numbers on the ground on the day, of course, aren't they? But I think where people are getting frustrated is that they can't get into whatever specialty it is, because we've got ACPs and ANPs and PAs across the spectrum of different medical specialties. So I think people are happy to work as part of a kind of a broad workforce, but they want to be able to get into their specialty in the first place. And I think that's the problem that need to tackle from a kind of a higher up strategic level.
Yeah,
more money, more doctors, basically fix the problem.
I think that there are a lot of trainees that are coming out and saying they're really unhappy with the Royal College, because they're like, look, they've come out using all these really strong words in favours of ACPs, but where are those strong words for us? And they just think it's a lot more political in the discussion about us. But yes, they'll come out with a really robust statement about ACPs, and we just want to see the same attitude towards us. And I guess I feel for them.
It kind of brings us on. It kind of brings us on to this next tweet by Yath Prem, and he says the NHS is losing incredible talent (open brackets) most forward-thinking junior doctors at a crazy pace, and from what I can see, they don't seem to be too bothered. It will be interesting to see the impact in a decade or so. I mean, this is kind of part of the problem, isn't it? Like, you make it so unattractive for the people in the workforce that they choose other avenues. They don't have to stay in medicine. There are things they can do. They can go to different countries. And I think Tech Priest, didn't he mention something about going? A lot of people had gone to Australia and New Zealand or something. Is that right? Yeah. I mean, it's a common phenomenon, and becoming more common from what we know. And you don't blame people for that. I mean, they've got to do what's right for them, right? There's only so much passion for the NHS will really get you, right? Because at some point, that passion is being exploited to the absolute limit, don't you think?
Yeah, I think one of the issues that we have is that the NHS doesn't always take an interest as to what people are doing when they leave. How long are they going for? Are they coming back? Why did they leave? There's no exit interview in the NHS really most of the time, and I feel like we can really learn from that if we sat people down and say, look, actually, what was it that we did? And how can we learn? We're talking about a no blame learning culture. Well, we don't really practice what we preach with that. There was, I think, is a lot of the time people do leave and then come back, especially at F3. Yeah. There was a really interesting report from HEE recently. It was a kind of a quality study. I think someone did it for their master's or PhD about the F3 phenomenon. Though there's not a lot in there about leaving to go abroad, because loads of my mates have, and I've had to mute them on Instagram because I can't bear to look at their much better life than mine. But it's really interesting to see why people take a break off training, for example, or just go and do something else. And I think that something like less than 30% of people go straight through training now from F2, which is incredible numbers. So there definitely hasn't been enough research into that, or at least a basic understanding as to why people are so dissatisfied with the traditional pathway.
I remember seeing a tweet, I think it was probably from a boomer recently though, saying that, a lot of the kind of medical students and FY1s are disillusioned by what they see on social media because everyone's so negative and all this kind of stuff. What do you think about that? Because obviously you have expertise like in social media. Like, what do you? Sorry, that's a weird way to phrase that, but
no, I know what you mean. So I think people see negativity and they remember negativity, but actually there's a lot more than just negativity there. And we realize we've talked about a lot of negativity tonight, but there is positivity tonight. But it's sometimes it's about what's newsworthy. Negative stuff seems newsworthy. People are going to go and talk about that. But one of the things I'm not going to plug my masters now, but one of the things I find whenever I speak to medical students particularly is that there's social media that is public and there's social media that is private, and generally a lot of the negative stuff is in the public domain, and in the privately people are going to go and just have their own communities and they're all supporting each other, they're all learning together. And particularly since COVID, because during COVID amongst students and I suspect amongst trainees as well, a lot of the traditional institutional authorities like universities or maybe some colleges or similar institutions have kind of abandoned their learners. And medical students in particular basically have gone off into these massive Facebook groups or similar just to go and provide their own medical education, for example. And so they're doing really amazing things if you kind of like peel back the curtain and have a look. And it's really inspirational. Literally, one of the people who marked my master said I was too reverential towards medical students, which I thought was cute, to be honest. It's really cool what a lot of stuff is going on social media, but we do talk about a lot of the negative stuff. But I think if you then look at the product of that negative stuff, there's a lot of good comes out, like with the tweets that Julia was sending last night, having a bit of an argument with some idiot turf, and out of that came a lot of people talking about pronouns and pronoun badges, and a lot of people, including myself, bought some pronoun badges. So that's good. So a lot of good can come from a lot of bad.
Yeah,
was that a segue?
No, yeah, it was nice. It's nice. We should talk about that. That's
very
good.
nice.
Oh my god, everyone's having a go. Everyone's having a go, aren't they, Imran? Jeez, another rival.
Yeah, he's like ST3 level now, isn't he? All right, well done.
I've got in.
Yeah, fair enough. So like, do you want to tell us about? So I missed this. I'm ashamed to say.
I can't believe it, Trusha. You're like the pulse of med Twitter.
I know.
Literally nothing runs through med Twitter without you.
I know. What was I doing? I don't know.
Yeah.
So what happened? So there's a turf. What did the turf say? Can we say it?
So Julia shared a story about how somebody in hospital had seen that she was wearing her she/they badge, pronoun badge, and asked, what's this? And that looks really good. And I can't remember the exact wording of the tweet, but it was a very empowering thing. And it was supposed to share positivity and kind of gender and kind of pronoun visibility.
Right.
And some idiot came in who just seems to have a really hateful account and said that she, there's a lot of nastiness that I won't repeat. Yeah. And then Twitter kind of descended upon them. And rightfully questioned gently initially, and then they just started lashing out really, really horrible, nasty things to some really, really nice people on Twitter, and then eventually they just deleted their account. Okay. So whilst that wasn't very nice, after that, Julia has posted a lot of like Q&As about pronouns, and a lot of learning has happened, and she put up a poll about do you have a pronoun badge, or do you display your pronouns at work? And most people said no, they don't. But a lot of people commented saying that they're going to go buy a pronoun badge, which I think is quite good.
Yeah,
Doesn't take
I mean,
much.
it's nice when, yeah, exactly. It's nice. I mean, I feel like I've learned a lot from being on Twitter. I mean, obviously there's a fair bit of negativity, but you try and take things as learning points and take something from it. It's usually there's something positive that comes out of the whole thing, doesn't it? Yeah. What do you think, Drusha?
They're quite predictable with their kind of arguments and stuff, but it's quite it's sad to see that they've kind of decided to descend upon her and Julia again, and they seem to kind of operate in swarms, and it's really just kind of predictable, banal kind of stuff, really. And there's this peculiar obsession with genitals. Oh my god, like the stuff about genitals, like they're obsessed, and I don't know, and sometimes they kind of go under the guise of like protecting rights of women. I remember once, like when I replied to TERF, they were like, "Oh, he must be a misogynist. Like I feel sorry for his female patients." And then I remember seeing that very same person responding to someone else being like, "You're ugly" and whatever. And it's like they're just to like to a woman, like it just their stuff's like rooted in misogyny, and it just seems so like hypocritical and just inane. And sometimes I just didn't quite know how to like deal with them, because I was just kind of bemused by how kind of peculiarly predictable, but also just like how their arguments didn't really make much sense, but also were just so kind of petty. And I don't know, it just if I feel kind of a bit sorry for them, but then at the same time they kind of seem to organize and be really quite malicious. Like I remember once they mentioned my children, and they seem to like kind of tagging in employers and talking about, and they always like they like to kind of like threaten litigation in some way, or like if your employer saw that. It's just so lame. It's lame.
I think, that same person replied to, did you see that? Replied to Chris, and they said something like, I want to know the names of your university, school, employers, your governing, but they literally had a list. I want all of this. And you think like, yeah, I'm not giving anything.
Yeah, exactly.
Why would I?
I'll send you my CV.
Yeah, have my CV, mate. Yeah. Just knock yourself out. Take my phone number as well while you're at it. Which leads us on to Tech Priest, doesn't it? Tech Priest this week complained about how his phone number got given out somehow. I think some do the email, the Scottish NHS email, and then apparently his phone number was on there, and it got given out like that. And you know what, Trusha, I might have to. The odd person to ask for your phone number, I've obliged. I've just given it to them. I hope you don't mind. You might be getting a few messages. If you do want Trusha's number, just feel free. I'll give it to you. I don't care. But Tech Priest wasn't happy. What do you guys think?
I mean, he was upset, wasn't he? He or she was upset. I think the thing is that it's like a massive breach of privacy, right? I can imagine though, like when if you were to try and get upset about this, as in if you're trying to kind of escalate this, I imagine the response would be like, oh, it happened, some kind of like terrible like excuse, and then nothing, because like that kind of level of incompetence is just kind of completely endemic throughout the NHS. Whereas if you make a mistake, like if you left out kind of patient verifiable data, like on a bus or whatever, you would get kind of reprimanded. You can lose it, like it could go it can go horribly, right? But because it's a medic, it's like, working the NHS, blah. And the interesting thing was, he was saying he's actually got a separate, he or she, sorry, has got a separate it's got a separate phone.
You're narrowing it down.
Oh god, I'm so good at keeping a secret, aren't I? It just like, what was I saying? He's got a separate phone for work, and so it doesn't. And even then, they gave out his kind of.
Well, that's the thing. He was saying that's been his phone number, or she was saying it was been his phone number for the last 12 years. So, I mean, to now have to change it is gonna. Maybe it's a good idea. Purge a whole lot of people that you don't speak to anymore.
It's just it's why do doctors have to do an SJT and not NHS IT? It just all sounds like a big SJT question, doesn't it? What I would do in that situation, I just reply all to the entire system and just break the whole system again, so they can nobody can access it.
Yeah, fair enough.
It does feel like one of the classic questions you get in those, when you go to a new trust and they'll be like, oh, you're in the lift and you could be talking to your colleague about this patient. Is it the right thing to do? Talk about the name and the et cetera, et cetera. You think, oh, come on, man. I ain't going to fall for that. And this is particularly juicy, then maybe. No, I'm joking. There was something about wellness retreats, wasn't there? Like wasting, and I tried to find this tweet, but it looks like it's since been deleted. So I probably won't mention the name of the person that said it. But do you remember this one? It was something about,
for God's sake.
we spend all this money on training and all this kind of stuff, but actually, anyway, yeah. Do you remember this one?
Yeah.
Oh, was this the one about wellness retreats and spoon making, spoon carving? Yeah. I just read this and I just thought, where are my wellness retreats? Why can't I have a wellness retreat? I love a spa.
Mate, you're living the wellness retreat. You're a dermatologist. That's
I was thinking this when I looked at this tweet. I thought, when I was a med reg, I used to love going to the spa just to that's the only way I could really kind of chill out, and I'd go for like a massage. Honestly, if I could have I could have afforded one a week, I would have done it. But obviously I couldn't. But I just thought, I've not been to the spa for a while, and I thought, well, it's probably because I'm not stressed and constantly screaming inside my head all the time. So that's a plus. Dermatology life is busy, but it's not quite med reg level.
Yeah, that was the one job I looked at and thought, no, absolutely not. It's just not going to happen anytime soon. I need to avoid that at all costs.
Speaking of which, so when you go to a spa, what do you get done? What treatments do you go for?
On me specifically? I just get a massage. Just a massage. Yeah, nothing like back massage, just to clarify that.
Just to clarify, because you know what the follow-up question would be to that one, I guess. We'll leave that to the imagination.
Yeah, exactly.
What about you, Imran?
I feel like you're really sexualizing me, guys, in this podcast.
I'm really sorry.
It's a theme that keeps coming back. It's going to be a Fesshole soon.
Yeah, absolutely.
Thrusha tends to do that to most guests, but mostly after recording. No, me. I didn't really ever get into massage, and then I got married, and then every time we went on holiday, Robbie wanted to go to massage, so I just got to choose something. In truth, I don't really enjoy it. I always find it really uncomfortable. I don't know what it is about it. Yeah, I'm one of these people that go, oh, ow, no, stop, please, ow. I didn't really understand. So we got there, we walked in, I thought, this ain't a massage. No. And I walked off. I was like, I'm out of here. And I just sat on the beach. And then it took a few hours for them to come back. They had a good time, apparently. Anyway,
oh, wow. Okay.
Yeah.
Well, I was thinking more would you like a pedicure or something? I quite like the idea. I've never had a pedicure, but I quite like the idea of having one. I guess that'd be quite cool. I have had massages before. I love them. But literally, I fall asleep though. So it's kind of...
Do you ever go for a massage after nights?
No.
It's a bad idea.
Is it?
Oh, just because you're so relaxed, and then suddenly you realize, and you think, have I been doing this for the last 15 minutes? You're like, A, that's really embarrassing, and B, I've wasted so much money.
Yeah, that is one way of looking at things. Yeah. That's true. No, I don't. I can never get into these things. I don't know. I don't know. Just find them very uncomfortable for some reason.
Fair enough.
Was there anything else that we want to talk about this week? I think.
There are a few. So there's one really, really good thread from Jimmy Lamb, and he was talking. Honestly,
yes.
I mean, I haven't heard people say stuff in passing about a carbon footprint from inhalers, but he kind of really does kind of discuss it in a bit more detail. I really recommend the thread. So it's from May the 9th, and it's by at Dr J Lam, Lam. And he says, a lot of work has been done in general practice to prescribe inhalers with relatively lower carbon emissions. More clinicians are being made aware that metered dose inhalers are by far the worst culprits. I didn't know that some MDIs are much worse than others. And he was he put in a table which kind of describes carbon emissions per inhaler. So the salbutamol, the free breath actuator, do you know the one that goes when you press the top? Have I put you in the picture? And that gives off 11 kilograms of carbon dioxide compared to 0.6 from an alternative Easyhaler. And I think he then goes on to compare it to actual a flight. Doesn't he compare it to a flight somewhere? No, it's like driving from London to Sheffield, 175 miles. It's the same carbon footprint as that inhaler.
That's amazing, isn't it?
It's amazing.
When you think about that.
It's awful. Why would you drive to Sheffield?
Have you seen the Full Monty?
Apologies to any Sheffield listeners.
They won't be listening to this. They'll be in the mind.
Take home point.
That's good. That's nice.
John, you were saying something about conferences as well, weren't you? You were saying that.
because when I first kind of read this, I just thought, well, first of all, like, why would you prescribe inhalers when you can just prescribe creams? It's so much better. But then I was reading about the carbon footprint of conferences and like meetings, and there was an example of the American Psychiatric Association's conference, which they had in San Fran in 2019, and 2020, obviously they went virtual, and basically this paper showed that the by going virtual, they saved the kind of the estimated equivalent of burning 500 acres of dense forest or 22 million pounds of coal.
Wow.
So that's a lot
Yeah.
of trees. Like, you know, if you think, you could have just literally burned like half a forest by just flying over to a conference for a few freebies. It's a bit, and that's before you even get into thinking about all of the like the free bottle of water that you get, the plastic bottle, or the lanyard you get. You know, it's pretty dodge.
Plastic straws. Yeah, I missed those. Yeah.
Think of the turtles.
Oh, poor little turtles.
What about my drink? Anyway, it's amazing when you think about that kind of stuff, isn't it? Like how much of an impact. I mean, you kind of think that being doctors and stuff would probably be a little bit more environmentally conscious, but that stuff like that does make you think. Actually, I mean, no, we're not. We're the same.
Exactly.
We're just as bad, if not worse, with some of the stuff that we're up to.
Yeah, I mean, like, wouldn't have thought about that. So thanks, Jimmy, for posting that. And there was this other kind of interesting thought which I saw, which is doctors who demand an RCT, a randomized control trial for everything, generally haven't done an RCT on anything. I discuss how easy it is to say do an RCT and how hard it actually is to do an RCT. It's long. I hope you read it. And the thing is that just been reading this book called Science Fictions, and it's written by a psychologist from Scotland, and he's just basically talking about the number of fallacies that there are, you know, just how badly research is performed, and especially like medical research. And I think one of the problems is, I guess, with like obviously the importance of kind of like maintaining ethics and things, but often means that there are lots and lots of hoops to jump through to recruit people for studies and stuff. But how a lot of these kind of the bureaucracy and problems recruiting means that you just end up with terrible research. And I guess it's kind of close to my heart, but where people just say, oh, do an RCT. And then there are lots of things, for example, in cardiology that we do with very, very little evidence. For example, like balloon pumps. And in America, they use something like an impeller device, which is like a kind of a device that you use for shocked patients, which is really, really, really expensive. But they just kind of like use it like for everyone, even though, and they're like, oh, but you know, like theoretically it can do this and whatever. And then it's just funny, like, and then for other things, like they're like, oh no, you need like RCTs for. And I just think it's kind of funny how we have this kind of weird relationship with research. I just thought that was kind of interesting to me.
You know what? I think a lot of what I do is probably not all that research driven in terms of like I do these steroid injections to people's shoulders, and I've heard and when I did look into it ages ago, like there was something saying that you're getting a steroid injection in your bum is going to do the same job as doing a steroid injection into the shoulder joint, but people still seem to want these things. And there's like hydrodistensions as well, which is something I need to keep doing every now and again, and a complete pain to do them for me, not the patient. Fair enough, they'd want to get the needle, but it's me doing the hassle. But apparently the research isn't that big behind it all, and you think, well, what am I doing it for? But it's kind of, I don't know, symptomatic relief. It's just something that we've always done. Kind of in your mind, kind of makes a bit of sense. Like, oh, if I put steroids where the problem is, then surely that deals with the problem, right? But research-wise, not very much behind it. I can see Johnny is just smiling away about talking about steroids. How much proof is there behind your steroid use?
You can't go wrong. No, I was actually thinking about because it's not just quant research; it's quality research as well, where it's just massively underrepresented in kind of the research world. Obviously, it's not RCTs, but if you look at postgrad medical education, for example, most of that doesn't follow any evidence. Like, why do we train people the way we do? Do we ever think about curriculum theory, for example? Do we ever try to put into practice some of the all of the older philosophical ideas that are supposed to drive a lot of this? No, we don't. We just do things because it's the way we've always done them. I go into a lot of rants about this usually on Twitter, but particularly about tick boxes for ARCPs and tick boxes for like recruitment and looking at points that you need to score. It doesn't make, like, evidence-wise, it makes no sense whatsoever. But we're medics and we like to rank each other, so that's often why we do it, which is really frustrating. And then the other thing I was thinking is that in quite a lot of research, patients aren't involved enough. And therefore you get this really skewed type of research where it's very doctor driven or medical driven, and because patients aren't involved, things aren't you don't get the proper recruitment, so you don't get enough underrepresented populations in your research. So there's in dermatology research, for example, in the States, I think Black patients in particular are massively underrepresented, and yet that has huge implications for the therapies that we provide. So this really goes quite deep in terms of how we practice research.
Yeah, more than skin deep.
Oh, nice.
Anyway,
nice.
Teed you up.
Sorry, yeah, thanks. I appreciate it. I swung at it, but that does lead quite nicely to a tweet from Quinn Capers, who was saying, "Please answer honestly, thoughtfully, and retweet. If a colleague asked me why do we need more diversity in medicine, I would have a strong, evidence-supported answer." And there were lots of people who strongly agreed. I must admit, it was something that I wouldn't have been able to quote a paper for, and so I'm really pleased to see that there were people who replied with papers. And may I humbly recommend a paper from the Journal of the American Heart Association, which is written by Quinn Capers, and he performs a systematic review and talks about various different things, the importance of diversity in medicine and how that influences outcomes. So there is evidence out there if people want to look for it.
Johnny, you were saying something about how diversity
training.
The diversity. I mean, there was something about how it can actually be detrimental to diversity if you have you were saying something like that yesterday, weren't you?
Yeah. So I mean, when I read this tweet, I kind of panicked and thought, well, if someone asked me that, I hate conflict, I would have just run out of the room. But when I went and had a little read about the kind of the issue, and I saw a few papers that I had kind of looked at before. But there was a really good one I saw in the Lancet. It's called "Working Towards Gender Diversity and Inclusion in Medicine: Myths and Solutions." And there's just like one paragraph which really stood out to me, which talks about diversity training. That kind of usually done in-house. They get somebody in to gather a lot of people, some of whom may hold certain stereotypes. And diversity training has actually been shown to be associated with reduced diversity, and it kind of worsens behaviors towards minority coworkers. And creates this kind of illusion of fairness, so that people who have experienced discrimination are less likely to be believed. Because if people say, "Oh, I've been to diversity training, I can't possibly be racist," so they recommend you need to go and link in with actual organizations who are trained to do this, because I think the evidence is a little bit better. And the general suggestion is that you need to create a culture that is more empowering to people to speak up, and gives people responsibility to call things out, just like we were talking about earlier, to be better allies, and also be able to stand up for yourself too.
Yeah, it's interesting, this, isn't it? I mean, you kind of from the outside think, oh yeah, great, having some sort of diversity is a great idea, but if it's not implemented the right way, then it actually has sort of almost the opposite effect to what you'd expect, right? It's fascinating stuff, isn't it? All of this.
Yeah. Well, I think the diversity training, like some things, can be a bit of a kind of a performative gesture, and so it's kind of it's when you do it for the sake of kind of not doing it, not really understanding it, but doing it because you want to give the illusion of it, and whereas kind of realizing or recognizing that it's important are two kind of different things.
I mean, we really I love education, but education is not a very good way of changing systems and changing cultures. You can't just go and teach it. It's similar to saying, "Oh, I'm going to teach everyone how to do VTE prophylaxis." Well, you might forget it in a few weeks' time, because systems change and people change. It's not a good way of kind of fixing these problems.
Yeah.
And the thing is that it matters, because there was a paper I was reading which was about dermatology diversity, and in the States, dermatology is like the second least diverse specialty, and it's one of those things that there's this good paper called "Why Dermatology is the Second Least Diverse Specialty in Medicine? How did we get here?" And the study talks about how, like, if you have got low percentages of underrepresented in medicine dermatologists, that perpetuates health disparities and actually care for minority patients, because minority patients are less likely to access healthcare. And they feel that they're less trusted, less listened to, and if they would have these kind of like physician allies. So diversity in a kind of medical workforce is absolutely essential.
Yeah, but I mean, like the disparity doesn't even stop there. So even not just even in access, but say for example, there was a study I remember reading about black babies, and they are much more likely to survive if they had black doctors, and that was the same for black women in labour. And I remember there was another study that looked at women, didn't they? So women were more likely to survive if they had women surgeons, and I saw this other actually that paper from Quinn Capers. He talks about how unfortunately in consultations it would seem that white doctors are much more likely to command consultations more if they had a black patient than if they had a white patient. So there'd be more that even their approach to consultation would change. And I imagine there's probably like unconscious things that's going on there too. But like it just kind of goes to show that there are things that we can't train out, as you say, like can't necessarily train out, and just simply by having a diverse workforce, there's osmosis and whatever, isn't it, that causes kind of changes.
I guess it's just an awareness of some of the issues that can arise, and accept that these can be potential issues is part of the way there, isn't it? You know, because that's part of the problem half the time when something gets brought up and someone doesn't believe you, or they think, well, you know, that clearly can't be true, and you think, well, I'm living it, or I've seen it, and they don't take that seriously because they're not even aware that that could be a problem because of their own life experiences, isn't it?
That leads quite nicely to another tweet. There was one from Benita Kane who talked about her daughter has long COVID. And she said, I tried for 6 months to get her research bloods done in the UK, hitting brick walls. In desperation, I took her to Germany in February. And they tried some kind of experimental treatments out there. And I think things are improving. But she had a massive response. She said that she was getting DMs from all kinds of people. And I think we were talking about this yesterday, weren't we? About how it perhaps is increasing our understanding for patients who would have had chronic fatigue syndrome or ME, like understanding post-viral syndromes better. And isn't it kind of sad that it's taken this like massive trauma for people to be like, oh, actually about stuff and considering it more closely.
Yeah. I mean, we're just finding out now that I think the recent research said that MS is supposed to be essentially long EBV, and people take MS seriously. So you know, there's a lot we need to learn. I feel quite passionate about this because again, it comes back to patients being involved. A lot of this comes from back. It goes back to the HIV/AIDS crisis in the 80s when there was a real patient movement towards patient and public involvement in research and practice, because obviously there's certain communities and patients who weren't believed. And there's lots of kind of discrimination there with that particular crisis, but there are echoes of it in things like long COVID and ME, fibromyalgia, the kind of medically poorly understood problems. And just generally throughout all of the commonality throughout all of those threads, which are quite different, is essentially medics don't listen, doctors don't listen, and we take too long, and patients are about 20 years ahead of us. Like in dermatology, we've got at the minute, we're kind of grappling with this concept of topical steroid withdrawal syndrome, which is something that we don't really understand. But if you look it up on TikTok, you're going to see millions and millions of hits, and yet you'll have dermatologists who hadn't heard of it 6 months ago, which is really interesting. People would say it's not a thing, but we're kind of coming around to this now. It's really complicated because evidence is so slow to build around these things.
Yeah, well, it turns out you can learn a few things from TikTok, eh? Well, not from me anyway.
You got some interesting responses to. Wait, was that on Instagram? You'd done like a chest X-ray teaching, and you were getting some.
Oh yeah, no, I think someone had tweeted something, and then they were saying, "But does that X-ray look rotated?" And someone tagged me in, Dr. Glasser, do you think it's rotated? So I thought, fine, I'll do a quick TikTok and I'll explain what rotation is. So I explained it, and then I just left it on the TikTok and downloaded and put it onto Twitter. But on TikTok, it went a bit nuts. I think it's got like 143,000 views or something. But then what's happening underneath it was people start complaining about their own sort of health problems, even though it's got nothing to do with it. And so I think this lady was like, oh yeah, like I had some problem and the doctors missed it. and it's so ridiculous. And I should have got a chest X-ray ages ago. And I said, yeah, but I was talking about rotation. Like, what are you talking about? But I didn't get involved. But then someone else underneath was like ND 125, 125, 125 was like, oh, and so asking about symptoms and all this stuff. It's like, we don't know who ND 125, 125 is. Why are you taking a history, mate, in the middle of a TikTok?
This is so scary, this stuff, honestly, because there's sorry, I ramble a lot about this, but there's a lot of doctors on Twitter. There's a lot of doctors on Instagram, usually kind of plugging their own influencing stuff. But on TikTok, there's not. And Reddit, honestly, go on Reddit and look up any condition. You will find thousands of patients talking about this kind of stuff, and there are no doctors there. There is nobody of kind of official repute giving advice on this. And so that, again, opens up a vacuum to people who might not necessarily be qualified or the person that you want to be giving advice. And so you get a lot of alternative opinions. You do get a lot of patient empowerment and people supporting each other, which is great. But there really needs to be work done by, like, on leadership and institutional levels so that doctors can navigate social media, so it's not just Twitter, so that they can anticipate and go on TikTok, for example, and say, well, look, if you want to learn about this, go on here. But I can't imagine it takes a lot of effort.
Yeah, I mean, I think I actually had to do a talk for Warwick the other day about radiology, and I think one of the things I wanted to tell them about is that, you know, when you're a student, or even when you're a medical student and you go through, even as a junior doctor, if you turn up on social media, you suddenly become the go-to person. That's just it. They don't see anything else. Because you're a medical student, they think you're super clever, super smart, you know loads already. And when you've got a DR in front of your name, they already think that you know everything. So even though if that patient turned up to hospital and then some F1 who just qualified yesterday, that F1, no offense to the F1, they might be very good, but would probably be the last person you want to see when you're sick. But on social media, that person becomes the first person you want to talk about because they seem so like cool. They seem like, you know, charismatic. They're in the camera. So I was trying to kind of, I felt like being a bit of an old grumpy old man, but I was a bit like, you know, it's very easy to try and pretend to be something that you're not necessarily are. And it's very important that you know that when you put yourself out on social media, please do not, like, I don't know, start giving advice. I mean, talk about what you know, but because I should send you this, Trusha. I saw a YouTube guy and he was a medical student and he was talking about a career in radiology and he's like a third year medical student. And I was like, whoa, that's a bit weird. So I listened to it and some of it was accurate, but some of it was like, he said, oh, they don't do ward rounds, which is true. But then he was like, yeah, I don't think I like that because, you know, I think ward rounds are awesome. And I was like, yeah, but you've done none. Like, you're a third year medical student. What are you talking about? But this is what I mean. Like, I think then there was always comments like, that was a really good video on like a potential, you know, career in radiology. I was like, I'm not sure that's a good thing you did there, mate. I think it's a bit of a disservice there because I don't know what you're reading, where you're reading it from. And you're only a third year and people are taking you very, very seriously and might take what you say to be true, which and some of it was inaccurate. So I do think it's a very, I mean, obviously, Johnny, you're doing research into this topic, but yeah, it does get a little bit dodgy. And I do feel like sometimes people are not aware of the responsibilities that are bestowed upon them just by the fact that they are
presentable
of the medical profession.
It's kind of about like the social capital is completely skewed. Social media is supposed to invert hierarchies and disrupt hierarchies, but that's not necessarily always a good thing. When you're talking about giving accurate advice, I mean, my big bugbear with this is whenever you get medical students calling themselves doctor on social media.
Yes, I've seen that.
Yeah, I've whinged about that before. But it happens because people say, "Oh, I want to save the handle for whenever I am a doctor," and you're just like, I mean, you're a second year, bit presumptuous. I mean, the odds are you're going to pass, but who knows if Instagram's still going to be around whenever you pass. It's pretty dodgy. I think students are able to calibrate around that. In my master's work, a lot of students would tell me that they would far more trust consultants, even if they've only had like a couple of hundred followers on Twitter, ahead of, you know, doctor medical students 1, 2, 3, 4, 5 who has 10,000 who's just sharing kind of gifts. So yeah, it's are you doctor medical student 1, 2, 3, 4, 5? So yeah, but there are lots of vulnerable people out there who will follow the wrong advice.
Yeah, and I just worry that, and I think also, when I still think that being a medical student is quite young, and I think social media can come up with the challenges and stuff like that. And I mentioned the dog story where I thought I might actually lose my degree because I may have apparently had a group that didn't like talk about not liking dogs, but
I remember that.
but like that was scary. I mean, that's when I first had that idea of like, oh, social media is actually like a potentially dangerous place. Like I was just doing what I wanted. But then when you realize that this could be the implication of, that's when I changed my name and everything for years. And that's why you got to be careful, because this stuff can stick sometimes. Thankfully, it didn't for me, but it can, in this day and age, it can do. Yeah. Anyway, social media. Well, that's pretty much what this entire podcast runs on.
Yeah,
and,
exactly.
It sounds like you're doing a lot of work in that field, don't you, Johnny? So yeah. Well, I mean, I guess we've been through a fair few subjects, haven't we?
Yeah, we're at
Johnny,
time, I think.
thank you so much. I mean, Thrush, did you want to go through anything else, or?
Can I mention one more Fesshole thing?
Oh wait! I mean, if it's Fesshole, it's got
yeah.
it's like the golden ticket. Yes, go for it.
So
Fesshole,
May the 9th. So was tipsy at a restaurant and flirting with cute waiter. I wrote my number on a paper napkin, put it in my pocket, and later handed it to him, saying, "Here, use it sometime," and left. Next day, I found the napkin in my pocket. Must have given him a used tissue. Never went back there again. Mate.
That's brilliant. Yeah. All right. Well, on that note, thank you so much, everyone. Thank you, Johnny. I mean, we've obviously interacted prior to this podcast, and I really do admire the work that you're doing on social media. I think it's going to be very, very important.
You're very wise. You're very wise.
Thank you.
I mean, potentially very, very, very important work, isn't it? Especially the way things are at the moment. I think it is. And as always, my Twitter, try and not get yourself into trouble. Let's not get cancelled, and have a great week. All right.
Bye, guys.
Bye.